We've got a very interesting person here today. He qualified as an optometrist, having graduated from City University in London before going to study medicine at the University of East Anglia in Norwich. He started ophthalmology training, a specialist training, in 2009 in Sheffield. After 3 years, he transferred to the London Deanery, where he completed the final 4 years of ophthalmic specialist training, including rotations with Moorfields Eye Hospital and the Western Eye Hospital. After completing a years of intensive fellowship training in cornea, external diseases, and anterior segment surgery, he took up his consultant post in the South Tees University Foundation Trust in 2016. He now leads the Cornea and Cataract service there, and he spends the majority of his time working also in the James Cook University Hospital in Middlesbrough. This is Trushar Patel. How are you doing today?
I'm good, thanks, Pansy. It's nice to talk to you.
Thank you very much for joining me. And one of the things that made me to reach out to you was the fantastic feedback that you've been receiving from your patients. It's always really nice to have this feedback when you've done something that can change a patient's life. What would you say is, the one instance that stands out to you the most?
Yeah, it's interesting. It's always really gratifying to receive thank you letters, thank you notes, even just compliments in clinic face-to-face with patients. And really it happens on a daily basis for most eye care professionals, I would expect. One particular instance that does really stand out for me, I shared it. I shared a picture of the post on my Instagram of a thank you note that I received from a patient who I diagnosed with conjunctival malignant melanoma. This was following a really good, a really informative referral from an optometrist. Okay. With all the pertinent information. And consequently, I was able to triage the patient and see the patient very, very swiftly within a week or so of receiving the referral. And what was striking was I don't manage these patients because in the UK, thankfully, we have 4 ocular oncology specialist centres, of which Sheffield is one. And I'm fortunate, having been trained there and still having really good relationships with my colleagues there, to be able to refer patients quite promptly to the team there. And so I organised the referral. I had some dialogue with my consultant colleagues there just prior to actually asking the patient to visit them. And essentially they confirmed the diagnosis, they managed the patient, they treated the patient. And I think it was about 4 or possibly 6 months after I'd referred the patient. Obviously, I was still getting information from the team there as to what treatment that they were offering the patient and how she was doing. But the patient then sent me a thank you letter. And in that thank you letter, she actually, as a team, and had a role in saving her life. So it's not always apparent as ophthalmologists or eye care professionals. We're looking after not just the eyes, but the whole individual themselves. So that really was quite thought-provoking for me. It was, just when you think of it in that context, that not only are you trying to preserve and save someone's eyesight, but at the same time, you're trying to ensure that they don't develop any life-threatening consequences of their disease.
You're a consultant at the South Tees Hospital and also work with the James Cook University. So what does your day or week look like? What are the sorts of patients that you get to see in your clinic?
It's quite a busy week. I do 5 clinics a week, and I do 2 theatre sessions a week as well. So it's pretty intense. I mean, they're all my clinics. I do 1 cataract clinic, but otherwise 4 of my other clinics are really just devoted to the management of patients with corneal problems, external eye disease problems, cataract, lens-based problems, these kind of things. So basically, I kind of, in a simplistic way, I kind of deal with everything from the lens to the front of the eye and the external part of the eye. So yeah, it's that predominantly occupies the majority of the time. And then I do work in the independent sector as well. So I do some private work and also provide as a cataract surgeon, provide services as a high volume cataract surgeon for some independent sector providers. So that's, in a nutshell, that's what I do on a day-by-day, week-by-week basis.
So your days are actually really quite varied because you've got so many things that you're covering. It's really reassuring when we've sent something across to you that's actually had an impact to your life. But do you think there are some mistakes that maybe we've made when we are referring to your clinic? Is there something that we can do as optometrists to help you out in your clinics?
It's always challenging. Having been on that side of the professional table, if you will, as an optometrist, it can be quite challenging. So I wouldn't say I've ever really received a mistake, if you will. Obviously, there are times when we do receive possibly inappropriate referrals or referrals that make it difficult for us to adequately triage patients and things like that because of lack of detail or pertinent information. But on the whole, the referrals that we receive are really very, very good. Of course, we all work within the limits of our experience and our competence. There are times when I'll be referred patients with a little mark on their cornea, which is completely visually, clinically insignificant, and obviously optometrists, an abnormality may not be able to identify what that abnormality is, or more importantly, whether that abnormality is going to lead to something that's significant and may threaten sight or may impact on the patient. So I generally tend to try to ensure that I empathize with the referrer and understand, from what perspective they're coming from in terms of referring the patient. So yeah, that's my take on it, really.
Well, I actually had a patient the other day when I was locuming in practice where she'd come in and she was very concerned because she had BCC on her lids and she had that removed. But then she came in and said, I feel like my vision's changed drastically over the last month or so, and I feel like something's not quite right. So in that sort of situation, I had a look on the slit lamp and saw that there was some corneal hazing, so pannus, and there was a there appears to be some kind of brown pigmentation on her cornea as well. So in that sort of situation, I thought, well, although I'm being extra cautious because there doesn't appear to be anything causing her any pain, because there's been such a drastic change in refraction over, the month period, I did do a referral. And, it was really nice that the consultant did send information back. So having that conversation with you guys and having that feedback from you guys is really, really quite helpful. A family member also has keratoconus, and vision's actually poor in one eye after she's had her cross-linking. So what are your thoughts on the treatment options for keratoconic patients? Do you tend to get involved in like the complex contact lens fittings as well?
I mean, the bulk of the referrals that I receive from primary care from optometrists is keratoconus queries, suspicion of keratoconus, etc. So I triaged a whole load of referrals just the other day, and the vast bulk of them were keratoconic referrals. My practice, the way I tend to initially manage these patients is I ask our hospital optometrist to do a refraction, and then on the day they have a corneal topography, and then I tend to review these patients virtually, especially since the pandemic. So what I do is I look at all the scans, and our optometrists are excellent because they take a full history, which I can then read through. So in terms of risk factors for progression, like atopic eye disease, ethnicity, eye rubbing, soft contact lens wear, these kind of things are important for me to know. And then I review all the refraction data, review the history, review the topography, and then I make a judgment as to when the patient needs to be seen again. Yes, cross-linking has made a huge positive impact on dealing with patients with keratoconus, especially patients who present with mild disease, so where their keratometry is is still hovering around the 43, 44, 45 diopter. In those patients, cross-linking can stabilize their condition, and they can they can manage with spectacles or contact lenses that can be dispensed in the community. Some keratoconics where the cone is not affecting the visual axis, so it's paracentral, and they've got minimal steepening, can have unaided vision of 6/7.5, 6/6 sometimes. And so obviously those patients are very difficult to pick up and screen for in community practice, unless perhaps you have a topographer where you can pick up subtle disease. In terms of managing patients who cannot cope with spectacles or simple contact lenses, so whether that's soft contact lenses, which are very few, or simple RGPs, I generally have a stepwise approach in terms of managing with these patients. Often the disease is very asymmetric, so it can be quite advanced in one eye, where they can have best corrected 636, 624 vision with an RGP. They may be able to get to 6/9, but not with the ideal fit. But in the good eye, they can achieve 6/6 with a simple spectacle prescription. And then these patients, I generally try to understand whether or not they've got some degree of binocularity. Because it's quite, patients have to be really motivated to want to take it to the next step. So the next step would be obviously to try and fit them with a contact lens. And then obviously, as you know better than I do probably, that that there is a whole host of contact lens options that are available to patients, not just RGPs. I don't get generally involved in the management of patients for contact lenses. I don't have that level of expertise now, because I don't see these patients. I generally pass them over to the contact lens team, and then they do whatever they can for the patients. Some patients, when they achieve really good, exceptional vision with a contact lens, are really, really happy. The problem is that the comfort, the wearing time, the tolerance can be limited. So when we reach that sort of stage or that obstruction, then I look at the corneal topography and I wonder if if they can have intrastromal ring segments placed into the corneal stroma to try and normalize the corneal topography, so that either the RGP fits more adequately, or they can then switch over to a potential soft contact lens. The field of refractive surgery is developing at such a fast pace. There's now the option of implanting Collamer lenses into the eye, which essentially sit behind the iris plane and in front of the crystalline lens, front of the crystalline lens. And I think this is potentially a really good option for keratoconics who have quite complex prescriptions, where obviously they're needing more involved or surgery, so intraocular surgery as opposed to just surgery on the surface. And then obviously inevitably there are going to be some patients who may need to progress to having a corneal transplant. And that can be unavoidable, especially patients who present with advanced disease, where they've got quite marked corneal thinning, where they've got an apical scar from the progressive rapid stretching of the corneal stroma. And obviously much rarer now, thankfully, patients who present with acute eye drops because of their disease. So those patients sometimes do need to go on and have corneal transplantation. And so as you can imagine, a consultation with a patient with complex keratoconus can be quite time consuming, talking through all the options, trying to gauge functionally what level of vision patients need. It's not always necessary for patients to have 6/5 vision in both eyes. some patients lead a completely normal functional life with 6.5 in one eye and maybe 6.18, 6.24 in the fellow eye without going through all the lengths of what we can potentially offer.
Really quite difficult and challenging, most of these things that you're having to do. The surgeries themselves are quite complex. Are there any particular ones that you can think of, any that come to mind that are really challenging that you have to deal with?
Yeah, there are. I mean, the operating room, the theater is quite a intense environment, especially when you're dealing with something as precious as someone's eye. A corneal transplant on a patient who I actually transplanted before. She had very advanced keratoconus, and she had a penetrating keratoplasty in her left eye. I think it was her left eye, and she achieved really good vision. With unfortunately, she's needed an RGP, but she tolerates it absolutely fine. She gets 6.5 vision with the RGP lens, and she was really happy. But unfortunately, the right eye was really advanced. I mean, I think at the thinnest point of the cornea, at the apex of the cone, we were looking at about 160 micron thick cornea with quite extensive corneal scarring. The rigid gas permeable lens just would not sit correctly on the eye. It was causing a discomfort. So I took the decision to actually do a deep anterior lamellar keratoplasty. So this is just replacing everything as much as you can above Descemet's membrane. So right. if you can preserve Descemet's membrane and the endothelium, then obviously that means that patient potentially cannot get endothelial, well, it'd be impossible for the patient to get endothelial rejection. And that's the most important structure within the cornea in terms of longevity and survival of the graft in terms of vision. So I did a manual dissection. So I did a layer by layer dissection freehand, and I managed to get down to about 50 microns. And I thought at that point that I would just leave it there, because the problem is what you can end up doing, as you can imagine, is if you're wanting to just go that little bit deeper, you can jeopardize the whole operation, and it can potentially perforate the eye, and you can end up having to convert the patient to a full thickness graft, which really, it's very challenging. Because if you imagine, the way I explain it to patients is, if you imagine you've got some sellotape stuck on some piece of paper, and that's what corneal scarring does. It sticks down very firmly on all the layers within the cornea, but also sticks down very firmly on Descemet's membrane. And Descemet's membrane really, as you may know, it's only in a healthy state, only 8 microns in thickness. It's literally just a sheet of cells lined, on one another with a basement membrane. So, the site of the perforation was away from where I was dissecting, but the stretching forces just meant that, we ended up, these are the types of challenging cases that, all corneal specialists will deal with within their practice.
Are there any situations where you feel like maybe, I don't know what's going on with this patient? Like, do you have a way that you can talk to other ophthalmologists to ask for help maybe?
Yeah, we've, my peers are fantastic. My colleagues within my own department and neighboring departments, and I've referred patients. I've referred maybe 1 or 2 patients to Moorfields for their opinion. So it's a very open forum, and there's always people to turn to. It's very infrequent that you're faced with a scenario or a patient that you don't know what to do with. There obviously comes a time when you may be faced with something that you've never seen before, but we just go through a systematic approach in terms of working the patient up. Just as someone who goes to the GP or to the accident emergency department with shortness of breath, they'll be worked up. You may not be immediately apparent what the cause of their shortness of breath is, but through various investigations and things like that, you can come to a pretty firm diagnosis. So there are certain things at James Cook that we don't have in terms of diagnostic equipment. So in the context of patients with, for instance, infection, and despite taking biopsies and samples, you may not be able to identify what the organism is. You sometimes have to do other non-invasive means of examining the eye. So confocal microscopy is a technique where, you know, a high an intense microscope can look at the cornea and try and identify any characteristics of the morphology of the pathogen and the disease process to give you some idea of what's actually going on. And so sometimes I refer patients to other units for those type of assessments and things like that. But yeah, you know, we're always being challenged by our patients. But that's what makes things interesting.
Of course. And, you know, one final question for yourself. You started off as an optometrist and, you know, you've worked your way up to where you are now. What advice would you give to anyone looking to work in that hospital environment, especially, you know, anyone that might be looking to get into your specialist field? Any advice, any suggested training or development that you would have?
Yeah, I mean, it's always really welcoming when optometrists get in touch, and I have some optometrist colleagues who refer patients to me directly on a first-name basis. You know, it's really nice when they approach, you know, and just be kind of open and say, look, we're kind of lacking in this particular aspect of, say, corneal infection, for instance. You know, is there anything, you know, what do I do in this scenario? And just ask questions and just develop some links with your local ophthalmologists, because, you know, we really welcome it. We want a dialogue with the community optometrists. We want to make your lives easier. At the same time, we want patients' journey through the referral process and coming into the hospital eye department to be relatively seamless. Yeah, I mean, you know, we're always available for advice as well. So, for instance, you know, a lot of times when patients are just sent to the eye casualty department, and it may not necessarily be a same-day referral, but they've just been asked to go to the eye casualty department, you know, just ringing the on-call ophthalmologist and just saying, I've got, you know, this particular patient, so this is the history, this is what I'm seeing. When do you think, what's the most appropriate time frame for the patient to be seen? Do they need to be seen? Is it by the GP or is it direct to you guys? And we can do that. But in terms of your development and learning and things like that, you know, I'm certainly more than happy to support my local colleagues. I found the local optometric committee to be really helpful because they kind of, from my own perspective, represent optometrist needs and things like that, and then they can have that gateway to speak to us, and then, you know, we can organize, you know, teaching. If it's teaching that optometrists need, then obviously we can organize that. And there's always opportunity to shadow as well. At the moment, it's a little bit difficult because of the pandemic and the constraints that we have with regards to social distancing and the number of people we can accommodate in the department. But I've had optometrists come and spend a day in my clinics, and they found it really useful and eye-opening, and you know, it's really nice because you know, I've got a different perspective because I've been on that side, as I've said, and I know how difficult it can be. You know, I've locumed in practices. I'm the only optometrist in potentially a rural practice, and you see something funny and you're thinking to yourself, well, what do I do? So I can still kind of recollect all the many
After
years
all your
ago.
years of experience now.
Yeah, it's all gone in the ether, but yeah, it's.
Well, thank you so much for taking the time to speak to me today. I'll let you get back to your very busy clinic, I'm sure. But if there's any other questions that I have from my students in the future, I'll be sure to get in touch with you again, and we can have another conversation in the future.
Great. Thanks very much, Nancy. Thanks for the invitation.
Thank you.